Hi, my name is Hans Hammers. I'm a medical oncologist at UT Southwestern Medical Center and the Harold C. Simmons Comprehensive Cancer Center in Dallas, Texas. Welcome to this educational activity on expanding therapeutic developments in the management of kidney cancer, during which we'll explore advances with frontline treatment. In subsequent segments, I'll introduce my fellow Dr. Lay from our group here at UT Southwestern, and also we'll be visiting with one of our patients, Mr. Robert Wilonsky. Our goal today is to explore some of the recent advances in advanced renal cell carcinoma, particularly immunotherapy and immune-targeted combinations, and describe what these have meant for patients suffering from this disease. Let's begin by reviewing the overall management landscape and some of the tools we can use for risk-adapted therapy selection. On this slide, you will see what we call the risk criteria. The truth is, kidney cancer is quite variable in its natural history, and when I see a patient for the very first time, I will try to gauge how aggressive is their disease. Am I really worried right now we need to use very potent, effective therapy right now, or is this somebody who has, for example, late recurrence of their disease and we can watch their disease? The survival can really range from months to years, literally. So in the early 2000s, Dr. Motzer and his group developed the Memorial Sloan Kettering criteria in the interferon era. And what was found is that certain clinical factors, such as decreased performance status and also decreased time from the initial diagnosis to systemic therapy, were factors that would predict patients would not do as well than patients who have good performance status or have the need for systemic therapy years down the road. There were certain laboratory factors, in particular anemia, high calcium, that would also help us to select patients who are at risk of not doing well. Really, at the end of the day, markers for disease burden, organ involvement, and the inflammatory state. Those criteria were updated by Dr. Danny Hang and Tony Cherry and their group, and we now have the IMDC criteria, which were really developed in the TKI, tyrosine kinase inhibitor era, and they were slightly modified, but really still carry most of the weight from the initial criteria, meaning decreased performance status, less than a year from diagnosis to systemic therapy, anemia, high calcium were still carried over into these criteria, but we also added neutrophil counts and platelet counts really as indirect markers for the inflammatory state. Patients who have none of those negative impacting criteria are what we call good risk, and they can do really well for a prolonged period of time. As you can see on this slide, in the very top, these are favorable risk patients, and this is their overall survival. And as you can see, probably independent of therapy, these patients do well, and the median overall survival is measured in years. If you have 3 or more of these risk factors, you are poor risk. And the median survival is typically more measured in the range of months. And then patients are in the middle, intermediate risk, 1 to 2 of these risk factors. They're kind of like in between those two extremes, if you will. And we use these criteria to get a sense for, how is this patient going to do initially when we see them, but we also use them, it's very important, for clinical trial development and for clinical trial stratification. So we want to kind of like get a sense for how many poor risk patients do we put on a trial, how many favorable risk patients and intermediate risk patients, and that might tell us something about how the cohort in general would do. And in fact, we also have a sense for that maybe some of these risk groups may be more amenable to some therapy versus others, and we will talk about that a little bit down the road. But really the initial take-home message is it's a quite variable disease, and we use actually fairly simple markers to risk stratify patients, not only for clinical use, but also for clinical trial development. And that is reflected in the NCCN guidelines. As you can see here, we are now breaking down essentially the patient population in 2 groups. Are you favorable risk or are you intermediate and poor risk? That is based largely on the outcome of one study, the Nivolumab, Ipilimumab, for which we really have only FDA approval in the intermediate and poor risk group. We use it sometimes in favorable risk group, and we'll go on that in a second. But I would say the FDA approval is in the poor intermediate risk group, versus other regimens such as combinations of PD-1 inhibitors with VEGF inhibitors are also approved in the favorable risk groups. And so we have preferred regimens for the favorable risk group and for the poor and intermediate risk group. And so it's important to know what is actually, so to say, appropriate or covered officially, if you will, by FDA approval. Nonetheless, if you look at the favorable risk group patients, they actually have quite some options. So if you look at the preferred regimens, that's typically Axitinib and Pembrolizumab, a regimen that had shown overall survival benefit, is preferred, for example, over Nivolumab, Ipilimumab, or Cabozantinib. But these are also regimens that are appropriate when the physicians feel there is a reason to use those particular combinations. At the end of the day, favorable risk patients have a lot of options. Often these are patients who have late recurrences. They have options of focal therapy, surgery, radiation. They have options for different systemic therapy. Probably the preferred version, at least in 2020, would be Axitinib and Pembrolizumab, but also the use of Nivolumab, Ipilimumab in selected patients, Cabozantinib, are potential options. But also patients may still use older immunotherapies that are a little bit more difficult to administer, such as high-dose IL-2, but have shown very durable responses. In fact, what we believe are cures in some of these patients with the risk profile of a disease. They can walk into a therapy that might not be too effective up front. In poor risk patients, it's really very straightforward. I would say the typically two most commonly used regimens is either Nivolumab, Ipilimumab, so a combination of two immune checkpoint inhibitors, or Axitinib and Pembrolizumab. Both of these are the preferred regimens because both of them have shown an OS benefit, over survival benefit in these patient populations. Axitinib avelumab is similar to Axitinib and Pembrolizumab, also a combination of a PD-L1 inhibitor in this case with a tyrosine kinase inhibitor, but this regimen has not yet shown an overall survival benefit and is therefore more in the category of other recommended regimens. So for poor intermediate risk patients, which by the way make up roughly 75 to 80% of the patients that you will see, are in fact these two regimens. Single agent TKI use, tyrosine kinase inhibitor use, I would say in general terms has clearly declined because patients would like to have access to a therapy that may lead to some more durable responses, maybe even with the chance of coming off therapy rather than being exposed to drugs that we feel are purely palliative in nature. Nonetheless, tyrosine kinase inhibitors remain the workhorses in renal cell carcinoma and have certainly their place and will keep their place in the management of that disease. What about second-line therapy? So that really depends a little bit on what you used in the frontline therapy. Typically, if you progressed on combinations such as Axitinib and Pembrolizumab, you would probably go directly to a more broadly acting tyrosine kinase inhibitor such as Cabozantinib. If you are coming off a tyrosine kinase inhibitor, monotherapy for example, you can then engage with Nivolumab as category 1 evidence, or Nivolumab, Ipilimumab, if you never were exposed to these immune checkpoint inhibitors. But there are also other subsequent combinations. Typically, if you failed, if you will, nowadays, immunotherapy, you will really be managed primarily with tyrosine kinase inhibitors of the VEGF pathway. So Cabozantinib is a very common initial choice. In some patients who have, not an overwhelming symptomatic disease burden, more selective tyrosine kinase inhibitors, if they were not yet used, are also appropriate. For example, patients who have progressed on Nivolumab, Ipilimumab, we may expose them to Axitinib, which is a more selective VEGF inhibitor. And when that drug fails, then we can go to Cabozantinib. After Cabozantinib, I often use Lenvatinib everolimus, again approved also in the setting after prior therapies, a very potent combination. I personally don't use everolimus single agent anymore simply because this particular combination seems to be somewhat synergistic and quite effective. But it really depends on the physician and the patient and in their discussions what would be used as next line of therapy. But typically we would use combinations or agents that have not been used in the front line or different classes thereof. Good. Let's look into the combination immunotherapy. Dual immune checkpoint blockade and immune target combinations are now really the front workhorses in renal cell carcinoma and the most recent additions to the practice guidelines. We'll now take a look at the evidence supporting their use in renal cell carcinoma, starting with immunotherapy combinations. But first, let's explore how dual immunotherapy can alter the immune and tumor microenvironment and are really the rationale for its use. You really have two primary targets with currently approved immunotherapy. One is called CTLA-4. This particular target is probably quite broadly expressed and also present in secondary lymphoid organs such as, for example, lymph nodes. So really even at the very earliest stages of the immune activation, when dendritic cells present tumor antigens, for example, to T cells, in that initial interaction, CTLA-4 plays a very important role and typically would downregulate activated T cells after initial stimulation. So you can really drive these cells in hyperdrive and unleash them, if you will, by targeting this particular pathway. The mechanism for CTLA-4 inhibition, however, are quite complex, and there are other targets, for example, in the tumor microenvironment, such as T regulatory cells, that probably also play a major role. If you look at PD-1, PD-1 is, if you will, kind of like an off switch for activated T cells, and the interaction of PD-L1, the ligand for the receptor of PD-1, is probably really important in the tumor microenvironment. So T cells are being activated, infiltrate the tumor, want to destroy their cognate target, but then the PD-L1 may interfere with the activity of these T cells, either directly from tumor cells or sometimes also from bystander cells, really stopping short the T cells effector response, if you will. And we have seen these sometimes dramatic responses with PD-1, PD-L1 inhibitor, which really revolutionized immunotherapy across solid tumors. And so the combination of these two is quite interesting because they probably have different targets, and that's the rationale for this particular combination. So now let's review some of the evidence leading to the approval of dual immunotherapy options with Nivolumab and Ipilimumab for advanced renal cell carcinoma based on the evidence of the CheckMate 214 study. This was a very large study, 1,000 patients, and it accrued all three risk groups. However, the primary cohort of interest, for which the primary endpoints were really designed for, were restricted to intermediate and poor risk patients. So 800 of these patients were intermediate and poor risk, and the co-primary endpoints, three of which were progression-free survival, overall survival, and response rate, were really designed for that particular cohort. There were secondary endpoints, for example, looking at the intent to treat population, combining all three, meaning favorable, intermediate, and poor risk. But really, the study was designed to look at intermediate and poor risk specifically. Clear cell renal cell carcinoma patients were accrued, stratified by the IMDC score and treatment region, and then either treated with Nivolumab at 3 mg per kilogram and Ipilimumab at 1 mg per kilogram, followed after 4 of these combination doses with Nivolumab at 3 mg per kilogram versus Sunitinib 50 mg at standard FDA approved dosing. I would say at this point it's important to note that the dosing of Nivolumab and Ipilimumab is different than the dosing regimen that we have used in melanoma. In melanoma, we have used a higher dose of Ipilimumab and a lower dose of Nivolumab. In the early phase of the development of these particular combinations in kidney cancer, we tried a higher dose that was used in melanoma and the lower dose in renal cell carcinoma, and roughly the response rate was the same, but the toxicity was higher with the high dose of the Ipilimumab. And so really the reverse dosing, if you will, than what we use in melanoma moved forward in renal cell carcinoma and also other tumors, for example, such as lung cancer. Good. So this is the overall survival actually for the intent to treat population, meaning all risk groups were included, good, intermediate, and poor risk. And as you can see, even for this unselected total cohort, you could see a very robust overall survival benefit, which in fact was statistically significant. Now, that was not the primary endpoint as per trial design, so it did not lead to the approval across all risk groups, if you will, but it still shows a robust overall survival benefit. The area in the red circle is of particular interest because in other diseases such as bladder cancer, lung cancer, we have seen that if you apply pure immunotherapy, which this regimen is, there was maybe a subset of patients who would have done better with cytotoxic chemotherapy, at least in their early treatment interval. The question was, is there a signal for that in renal cell carcinoma, meaning would there have been some patients that clearly would have benefited from upfront VEGF therapy to a larger degree that it would be visible, if you will, on the overall survival curve. And we really don't see crossing of the curves in that particular area. So that's quite reassuring that we are dealing with a very potent combination that does not always require the addition of a VEGF inhibitor. This is the overall survival for the intermediate and poor risk patients. So this was one of the core primary endpoints, clearly positive, very nice and broad separation of these two curves. And what you will see, this is now a curve with actually quite some follow-up, 42 months of follow-up. We will see that some of the other combinations have much less follow-up for overall survival. Currently, at the time of this presentation, we only have really 12 months follow-up for some of the other combinations. But here we have 42 months of follow-up, and what you can see is still a significant difference in the overall survival of patients treated with immune checkpoint combination versus sunitinib. I would also like to point out the median OS for patients at with the 42 months follow-up is actually 47 months versus 28 months for sunitinib. So that is a very significant increase in overall survival. And that will clearly affect the outcome moving forward for patients being treated with this particular regimen. Looking at the next slide, this is the progression-free survival for intermediate and poor risk patients. If you just look at the median, you really don't see much of a significant difference. But here you can see a very nice separation between these groups. Intermediate and poor risk, you can see that at 42 months, 35% of patients have not yet progressed, which is really what we had hoped for, that the tail would be forming and that patients could benefit from these therapies potentially long time. So these are patients who don't seem to progress and are really doing well. 1/3 of treated patients, which in our mind is really impressive. And this is really what we want to see, a plateau forming with long-term follow-up. That is some of the data sets that we don't yet have for some of the other combinations that were more recently approved. Okay, so this is now the confirmed responses by independent review for the CheckMate 214 study. And as you can see on the left, it compares the response rate for Nivolumab, Ipilimumab in green and for sunitinib in gray. And as you can see, the response rate is really impressive, 42% for pure immunotherapy for intermediate and poor risk patients versus 26% for patients treated with sunitinib. The interesting aspect of this is that roughly 10% of patients actually achieved a CR, complete response, versus only 1% of patients treated with sunitinib. This is typical for tyrosine kinase inhibitors, that we typically don't see a complete response, but the 10% for a combination immunotherapy was rather impressive. If you look in the middle for the intent to treat population, you can see that the benefit and the extent of complete responses was maintained with 11% of patients on the Nivo-Ipi arm versus 2% of patients treated with Sunitinib. Let's move over and look at the favorable risk group patients, which are on the very right. And there we really see something very interesting, because the response rate here is clearly higher in patients treated with Sunitinib than with the immunotherapy. And we do know from some histological analyses, other trials, that maybe favorable risk patients are somewhat less inflamed than patients with intermediate and poor risk disease. Nonetheless, we see again a clear-cut trend that there is actually a significant amount of patients with a complete response rate of 13% of patients in favorable risk, whereas again low single digits for patients treated with Sunitinib. The message here is that while it's not officially approved, if you will, FDA approved, for favorable risk patients, there's clearly a certain percentage, a significant percentage of patients who gets very deep responses to immunotherapy and may have some very lasting impact from that therapy, even though the overall response rate is less. Still very much debated how we should treat patients with favorable risk, but that's probably one of the reasons why the NCCN has Nivolumab and Ipilimumab combination as an option, as an alternative for patients with favorable risk disease. Looking at the durability of responses, I want to show you two different aspects of it. One is on the very left, you can see what we call swimmer plots. So these are patients who started therapy and are continuing on therapy. For example, in the very upper block are patients who are still on therapy, and every single patient there is what we call a swimmer. So every line is one of those patients, and you can see a large proportion of patients still continues on treatment. And there are some patients who had to come off therapy, typically because of side effects, and they had to stop therapy. And you can see where they started therapy in orange, and then you can see the extension of follow-up of therapy in blue. So there's a significant proportion of patients who actually comes off therapy. Roughly 22% of patients actually could not go on with Nivolumab monotherapy because they actually developed a significant side effect during the induction phase with the combination treatment. Yet you can see that patients can continue to benefit from this therapy, meaning you have durable responses, and there seems to be a memory, if you will, within the immune system to deal with tumors, even though these drugs have been removed. The median time to response actually is quite short and really is in the time frame of tyrosine kinase inhibitor therapy. Often there is a little bit of a bias that immunotherapy may need to take quite some time to work, and that's probably not really true with this particular combination. It's really in the time range of what we see for tyrosine kinase inhibitors. Importantly, if you had a complete response, the chance to go on and continue in the response is really high, 86% with a longer follow-up. And even patients who had to come off therapy, the median duration of this, what we call treatment-free interval, where patients were just followed, not really receiving a second therapy, and had a complete response, is actually almost 3 years. So that's a very significant benefit for these patients. Again, durable responses with immunotherapy, that's really something that we like to see. So this is the treatment-free survival for intermediate and poor risk patients who discontinued protocol therapy. So patients who did not receive all 4 doses of Nivolumab, Ipilimumab, could not continue with Nivolumab monotherapy and had to come off. And so people have looked at what we call the treatment-free survival. Patients who come off therapy will be followed, and not all patients actually will require subsequent systemic therapy. 24 months, you can see a clear difference in the treatment-free survival. 19% of patients treated with Nivolumab, Ipilimumab versus 6% of patients treated with Sunitinib. So clearly, the opportunity after 2 years for 1/5 of patients still not to require subsequent systemic therapy is a big difference in how we used to treat these patients with just targeted therapies, for example. Let's look at quality of life. And so here you can see really distinct differences between patients, typically more the chronic side effects and effect on quality of life. So these are two different tools, if you will, to assess patient-reported outcomes in quality of life, the FIXI-19 and the FACT-G questionnaires. And as you can see in both, the combination of Nivolumab and Ipilimumab was clearly superior with regards to the changes from quality of life from the patient's baseline versus patients who were treated with Sunitinib. So Nivolumab and Ipilimumab maintained a higher health-related quality of life and lower symptom burden than Sunitinib in patients with intermediate and poor risk disease. Let's look at some of the incidences of treatment-related AE by organ system in all in all treated patients. And there are clear differences between these two cohorts. On the very left, you see the Nivolumab-Ipilimumab group. On the right, you see Sunitinib. You can see that some of the more prominent side effects are high blood pressure. For example, that's why you see the pink curve very high on Sunitinib. But the other pattern that you can see is you can see these spikes of side effects depending on the timing if the patient was on the drug or off the drug. And they typically carry forward throughout the treatment period, if you will. There's some decline in some of the side effects, but typically of these constant side effects, if you will. On the very left, you see Nivolumab, Ipilimumab, and you can see that there's clearly almost like one big spike where most of these side effects occur, and that's typically in the range of 3 to 4 months. That's when most of the side effects happen, these autoimmune side effects that require immediate attention and close management of some of these patients. Roughly 35% of patients or so require prednisone for the management of some of these autoimmune side effects. But after that, the incidence for grade 3-4 events is really not common. Some of the side effects can persist. If you look at the endocrine line, for example, that's the top curve, you can see that certain side effects, for example, hypothyroidism, that we commonly see with this particular treatment is something that's more permanent and the patient will require supplementation with thyroid hormone, for example. This is another way to look at these side effects with, in this case, with columns, if you will. Low-grade events are in the light color and the high-grade events are in the darker color. Green for Nivolumab, Ipilimumab, and gray for Sunitinib. And as you can see, there is a tendency to have a higher amount of side effects initially for patients treated with Nivolumab, Ipilimumab, and then you see a nice clear reduction for later time frames. For Sunitinib, you can see the initial toxicity has some leveling off, but overall the toxicity profile remains higher than what we typically see for immunotherapy after longer periods of treatment. One question that patients ask is, well, you know, I had a side effect, a significant side effect, I have to come off immunotherapy. And so one of the questions, how well do those patients do? And so here you can see in the dark green line, the overall survival curve for patients who discontinued treatment because of typically immune-related adverse events. And those patients do the same, if not even a touch better than patients, for example, in the intent to treat a patient population. So just because you have to stop therapy because you had side effects does not mean that your outcome is worse. In this particular trial, patients could not continue with Nivolumab monotherapy if they did not receive all 4 doses of the combination therapy. Another interesting subset of patients that we see in kidney cancer are patients with what we call sarcomatoid differentiation. So this is typically a certain histological feature, not a histology in itself. It's a histological feature that we see in clear cell and in non-clear cell renal cell carcinomas. And typically it portends a much worse prognosis, much more aggressive disease, and a less response to tyrosine kinase inhibitors. What was really astounding is when we looked at the sarcomatoid patient population in a retrospective analysis of patients treated on this particular trial, we saw that the response rate to nivolumab ipilimumab was really high, almost 57% response rate, and the CR rate of 18%, really a home run for patients who typically face a very aggressive and typically devastating disease course, versus only 20% of patients responding to sunitinib and 0% SCR. So this is a very clear signal that probably these tumors are highly inflamed, and immunotherapy is the standard of care for patients with this rather aggressive histology. Another way to look at this are the progression-free survival curves, and you can see there's a very significant difference between these two curves for nivolumab, ipilimumab, and sunitinib treated patients, intermediate and poor risk with the sarcomatoid features. There are other trials that are building on this particular regimen or components thereof. There is, for example, the PDIGREE style, and I will go into that in a few seconds, that randomizes patients after the initial induction with nivolumab ipilimumab to maybe receive an additional tyrosine kinase inhibitor when they go on the nivolumab phase, which may have immune modulatory activity, so maybe squeezing out the most for patients who did not have one of the highly desirable CRs, for example, or experienced progressive disease. There are also combinations of a tyrosine kinase inhibitor with nivolumab ipilimumab itself, triple combination therapy, if you will, and all these trials are still ongoing or accruing. There's also now the combination of a pegylated version of interleukin-2 with nivolumab versus tyrosine kinase inhibitors, and all of these trials will inform us in how we maybe move immunotherapy further. This is the study design of the PDIGREE study. This is a cooperative group trial here conducted in the United States and Canada, and we would certainly encourage accrual on this particular study if possible. Here, patients treated with nivolumab ipilimumab will be randomized if they did not receive a CR and did not progress to either then receiving nivolumab by itself or in combination with cabozantinib, kind of like an intensification for patients who didn't have the best outcome that we had hoped for, and we want to see if we can further delay progression, or also see if we can increase the CR rate, the complete response rate, at the 1-year mark for some of these patients. So very interesting questions that are being asked here. So, so to further, explore how can we move immunotherapies forward, there's certainly the desire to combine it with the other class of drug that we have used for more than a decade, which are the tyrosine kinase inhibitors. And so with the next slide, we will look briefly at the rationale for combining VEGF inhibitors with PD-L1 and PD-1 inhibitors. So on this slide, you see the schema for what's required really for a successful immune response. In point 1, you have the cancer cells that some of them will die off. They will release antigens. These will be taken up by dendritic cells, and then the immune system will be primed, and T cells will travel and then return back to the cancer, hopefully, and attack the cancer. And VEGF inhibitors have really shown a multitude of effects on tumors. They can certainly destroy tumors. They can also, however, allow for T cells to better infiltrate tumors. So by decreasing, for example, intratumoral pressure, opening up the vasculature, T cells are known to be more invasive into the tumor microenvironment in the context of VEGF blockade. And so it's very tempting to say, okay, we have these two classes of drug, let's combine them and see what we can achieve in the best possible setting. So there's a scientific rationale, not just a clinical rationale, for combining these agents. So there have been numerous trials assessing the efficacy of various checkpoint inhibitors in combination with the inhibition of VEGF pathway in the first-line setting. And 2 of those combinations are now approved, and we will take a look at their efficacy and some of their quality of life or better their side effect profile. So as you can see, an avalanche of new combination trials are ongoing. Two of them have led to FDA approval: Axitinib in combination with Pembrolizumab, a potent PD-1 inhibitor, or Nivolumab, a PD-L1 inhibitor. The combination of bevacizumab and atezolizumab has been reported but has not moved or led to FDA approval, and other combinations are still in the wings. Combination of Nivolumab with cabozantinib, lenvatinib, another potent VEGF inhibitor, in combination with Pembrolizumab, or the trial that I mentioned earlier, cabozantinib in combination with Nivolumab and Ipilimumab as a triple therapy. So let's move on and discuss evidence for the combination of Axitinib and Pembrolizumab with the Keynote 426 study. This particular combination was approved in April of 2019, again conducted in clear cell renal cell carcinoma patients, had two primary endpoints: overall survival and progression-free survival, and other secondary endpoints such as response rate, duration of response, for example. So patients again were stratified by the risk groups. In this case, actually the primary cohort was the intent to treat cohort, meaning including not only intermediate and poor risk patients, but also the good risk patients, and also stratified by region. The treatment regimen was standard dosing Axitinib, 5 milligrams twice daily. The advantage of Axitinib is that this is a rather short-acting tyrosine kinase inhibitor, which makes it easier to discern maybe some of the side effects that might be overlapping with immunotherapy, because you can hold the tyrosine kinase inhibitor and see if those things improved, in combination with standard of care Pembrolizumab, 200 milligrams every 3 weeks, and then pitted against Sunitinib, 50 milligrams, 4 weeks on, 2 weeks off, as FDA approved. This is one of the key endpoints: progression-free survival, really impressive, with a hazard ratio of 0.69 and a median progression-free survival of 15.1 months. Really the first time that we have reached that far in the progression-free survival endpoint. Sunitinib did well in this trial with 11 months, so roughly 4 months difference in progression-free survival. If you look at overall survival, and this is with early follow-up, a little bit more than 1 year off, you could see a really impressive difference already in the median overall survival with a hazard ratio of 0.53, which is really impressive, and a 12 months survival of almost 90% for patients treated with Pembrolizumab, Axitinib, versus 78% for patients treated with Sunitinib. This is the response rate. Clearly a very high response rate, similar to what we saw in the early phases of these combinations, roughly 60% response rate versus 35% for Sunitinib. CR rate was higher than what we saw again with Sunitinib monotherapy, which was almost 2% for Sunitinib alone, versus 5.8% for Pembrolizumab and Axitinib. Not the 10% that we saw with the dual immune checkpoint inhibitors, but still an increase in the CR rate, and we still have to learn, if you will, how durable some of these responses are, since a tyrosine kinase inhibitor is now a part of the mix, if you will, and we don't know yet if there's true synergy or not for this particular combination. Interestingly, investigators also went back to look for the cohort with sarcomatoid features, and again, very high response rates. In this case, progression-free survival was shown with a 12 months progression-free survival of 57% versus 26% for Sunitinib alone, and a very good hazard ratio. This is the OS, progression-free survival and response rate for patients with intermediate and poor risk disease, to demonstrate the efficacy in the patients who typically do the worst. And here you can see again an impressive difference for OS, again with the hazard ratio of 0.52, a good progression-free survival difference with a 1-year mark of 56% versus 40% for Pembrolizumab versus Sunitinib, and again a high response rate, a little bit less than in the intent to treat analysis, but it's 56% versus almost 30% for Sunitinib. So again, a very active regimen, and clearly a regimen with the highest response rate that we've seen for patients with untreated metastatic renal cell carcinoma. We don't have a quality of life data yet at the time of this webinar, but what you can see here is the adverse event profile. There are really no major surprises. If you look at the volcano plot across the different adverse event categories, you can see they look really very similar to Sunitinib for Pembrolizumab. One difference and one important point to look at carefully is actually the high-grade toxicity with regards to the transaminases. We did see an increase in some of these side effects for patients treated with Pembrolizumab Axitinib. Interestingly, not all of these sometimes impressive elevations in transaminases are autoimmune in nature. So the initial step, in fact, is to hold the Axitinib, follow patients very closely with their liver function tests, and in some patients you can see a decrease in the transaminases just by holding the Axitinib. However, if it remains stable or continues to rise, you would have to start prednisone, because then it's most likely autoimmune in nature. The next combination is the combination of Axitinib and Nivolumab. This is the JAVELIN 101 trial, which was approved in May of 2019. Again, very similar design to the Axitinib Pembrolizumab trial. Clear cell renal cell carcinoma patients treated with Axitinib, standard dosing, and Nivolumab at 10 milligrams per kilograms IV every 2 weeks, pitted against Sunitinib. In this case, the co-primary endpoints were actually progression-free survival and overall survival in the PD-L1 positive patient population. For this particular trial, this was roughly 60% of patients were PD-L1 positive. For the Pembrolizumab trial, it was roughly 50% of patients. And for the Nivolumab Ipilimumab trial was roughly 25% of patients. But the difference in percentages, in particular for the TKI combination trials, was really the technique that was used in how to determine positivity. So if you look here at the primary endpoint for progression-free survival, which was the positive endpoint, there was really no major difference in the progression-free survival curve if you looked at the PD-L1 positive population, again roughly 60% of patients, versus progression-free survival for the overall population, and that led to the approval based on progression-free survival. We don't have yet an overall survival for this particular combination. This is something that we may get to hear about later in 2020. But so far, the only primary endpoint that was positive was progression-free survival, led to the approval of this combination in the United States and Europe. But because of the lack of overall survival thus far, this regimen is less preferred than the combination of Pembrolizumab and Axitinib. Good. So this is the response rate, which was a secondary endpoint. Again, a very active regimen, response rate of 55% for the Nivolumab Axitinib combination versus 25% for Sunitinib for the PD-L1 positive group, and a little bit less in the overall population, but still more than 50% response rate versus 25% for Sunitinib. So clearly one of the effective regimens with response rate above 50%, which is or has been before these particular combinations have not been seen in renal cell carcinoma. Complete responses were also seen, more similar to what we saw with Pembrolizumab Axitinib, a little bit higher than the sunitinib, which was around 2%, and in the PD-L1 positive population was 4% and 3% for the overall population. There were no major safety signals that were unusual. Certainly diarrhea, hypertension, a little bit more pronounced with the Axitinib over the sunitinib, and we also saw sunitinib causing more hematological toxicities with thrombocytopenia, anemia, and neutropenia. There's no surprise here. With regards to the safety concerns, the one thing I would say that is important to remember with the Avelumab is the actually higher incidence for infusion-related reactions than what we saw with other antibodies. So this particular antibody actually has the ADCC activity retained, and we do see more infusion reactions, which can be managed, but we do see more infusion reactions with this particular antibody than with other PD-1 or PD-L1 antibodies. Roughly 11% of patients required corticosteroids for the management of IRRs, and as a rule of thumb, I would say roughly 10 to 15% of patients treated with PD-1 monotherapy or in combination with these TKIs require corticosteroids for the management of autoimmune side effects. Actually, just very recently, we heard a press release that actually one of the other pivotal phase 3 trials, CheckMate 9ER, was positive by progression-free survival and overall survival. This is the first time that we studied a more broadly acting tyrosine kinase inhibitor, cabozantinib, with a longer half-life, so a different TKI background, if you will, in combination with Nivolumab. And so we are certainly looking forward to learn more about the details of this particular study, but it seems that another PD-1 TKI combination has demonstrated probably good response rate, progression-free survival, and overall survival, and will certainly be now a part of the quickly evolving landscape in renal cell carcinoma. So with this slide, I want to summarize a little bit. We've heard now about the dual immune checkpoint inhibitors, and we also learned about two regimens combining VEGF inhibitors and immune checkpoint inhibitors of the PD-1, PD-L1 pathway. And there are some differences in the flavor of some of these trials, and my goal is to remind you what some of the pros and what some of the cons may be, and I think this is a good way to approach patients when talking with them about these different regimens and see what they may steer towards, and maybe there are some combinations that are better for some situations than others. So what we do know for the dual immune checkpoint inhibitors is there's clear and improved overall survival. And the important thing with this particular regimen at this point in time is we do have more follow-up. There's just no doubt about it. We have 42 months now of follow-up, and the data looks like what we want to see. There's a plateau forming, a tail forming on the OS curve and on the progression-free survival curve. And the quality of life is really unmatched. You don't have the chronic toxicity of the tyrosine kinase inhibitors. You can have these autoimmune side effects, and they often require treatment, but if you follow patients closely, manage them well, you typically have to deal with these in the active phase only for a few days. Patients then improve, the side effects go away, the quality of life improves again, and then you have patients on a somewhat longer taper, typically of prednisone. The need for secondary immune suppressive agents really is in the single digits. So most of the time you can manage patients well with the timely institution of prednisone for these side effects. The cons are the higher rate of the immune-related adverse events. Roughly 30% of patients will require prednisone and immune suppression. Again, typically you're done with a 4 to 6 weeks taper of prednisone. Some patients, depending on the side effect, you can actually restart immunotherapy, in particular if the side effect happened during the Ipilimumab, Nivolumab combination. If you then go to the Nivolumab monotherapy sequence, typically it's much less likely that you cause major side effects during that treatment interval. However, as with any immunotherapy, the side effects themselves are somewhat unpredictable. You have certain higher rates that you can follow with endocrinopathies, for example, but you can see some rare, sometimes severe immune-related adverse events, and you need to monitor these patients closely for the first 3 to 4 months when really most of these side effects happen, and they're somewhat less predictable than with targeted therapy. You do have a lower progression-free survival and you do have a lower response rate. However, the response rate is still clinically very meaningful with above 40%. But you need to communicate with patients that more patients will eventually progress than respond, and patients need to understand that for that reason. IO-TKI combinations such as Axitinib, Pembrolizumab have also demonstrated now improved overall survival. We will have to see if other combinations can follow suit, and the overall survival may be one of the distinguishing factors between the Pembrolizumab Axitinib versus other combinations that may be coming. You do have the high response rate, and that can be really valuable for patients who do need to have a response early on. I would say not everybody needs high response rates early on, but in some patients it's really critical. Patients with very large tumor burden, patients with visceral involvement in larger quantities to avoid a visceral crisis, if you will. That would be quite useful to go with a combination that has a response rate of around 60%. You do have the longer progression-free survival. You do have a lower IRRC rate, immune-related adverse event rate of around 15%. Overall, you have the higher toxicity from the tyrosine kinase inhibitors, but the immune-mediated side effects that require prednisone is lower, roughly half of what you would see with the dual immune checkpoint inhibitors. So in patients, for example, who may be at higher risk for example, developing increasing myopathy, patients who have decreased mobility, for example, where a prolonged steroid taper may not be that helpful, and then agents or a combination of this nature might be preferable. One thing that is always unclear is that if you respond is what component actually had the major contribution. Did you shrink your tumors because of the VEGF inhibition or because you experienced the true immune response? And it's also still unclear yet when to stop the tyrosine kinase inhibitor with these particular combinations. One of the cons is certainly at this point in time the somewhat immature follow-up. We have good data for a little bit more than 1 year of follow-up, but we really want to see, do we see the plateau similar to what we see with the dual immune checkpoint inhibition, or do we have just the initial benefit of median overall survival, but maybe we are missing the tail, or maybe we don't get the tail to a level that we want to see. And certainly the lower quality of life with the chronic toxicity is one of the drawbacks of this particular regimen. And these are, I would say, some of the main points that I try to communicate with patients when trying to decide what the appropriate regimen would be for them when I see them the first time. So in summary, we've seen the evidence that supports different combination approaches for treating advanced renal cell carcinoma in the first-line setting, each with consideration that must be weighed by the physician, other clinical team members, and by the patient. In subsequent segments, we'll explore some of these practice issues in the context of interprofessional collaborations and illustrate how working with your patient can lead to better outcomes in renal cell carcinoma. So in this segment of the program, we'll explore some of the practical implications of the evidence on newer treatment regimens in renal cell carcinoma, really focusing on frontline dual immune checkpoint blockade and immunotherapy-TKI combinations. In part, we will focus on some of the differences between these options, including differences in safety profiles and what that might mean when discussing these treatments with patients and adverse event management. To begin, I'd also like to welcome one of our fellows from UT Southwestern, Dr. Treley, who's going to help give us a sense of how clinical decision-making can be informed by the wider oncology team as well as the patient. Hello, Trey, and welcome.
Thank you. It's nice to be here.
Okay. So let's start by doing a quick review of what we just talked earlier about of the treatment landscape in renal cell carcinoma. So again, these are the treatment options for the first line as delineated by the NCCN guidelines. And we are differentiating really patients by their perceived or estimated aggressiveness of their disease. Patients fall typically in either the favorable or the poor intermediate risk category. So Tree, how do you explain this complex landscape to patients, particularly to those who have some concept of, what immunotherapy or targeted therapy is, but who are maybe unsure about what it means to combine these options? How do you approach it with patients when you see them for the first time or they see you for the first time?
Absolutely. This is always a very difficult concept to approach, especially as I progress in my training. The first thing I try to do is kind of just give a brief blurb about what the mechanisms are. And while that's very fascinating to me, I certainly try to jump right ahead to what's important to the patient. And at the end of the day, what is the treatment going to do for them? What is the response rate? And what kind of toxicities they'll undergo? And especially with the treatments that you just mentioned, I think kidney cancer and metastatic kidney cancer in particular has the special place where we can get durable remissions and durable remissions that approach what we could consider a cure. And I think that's how I help the patients weigh, what the various combinations of therapies are.
Thank you so much, Lee. I certainly can appreciate how much the field has changed. I myself became faculty in 2009 and had the chance to observe how the field has changed from really purely palliative approaches with tyrosine kinase inhibitor monotherapies to now immune checkpoint combinations, either to different checkpoints or with TKIs, clearly moving in the direction of durable responses, and maybe some patients doing extremely well, curative potential. It's something that we're all hoping for. So certainly very different discussions for first-line patients these days than even just a few years ago, such as 2018 when the first of these therapies became approved. So why don't we take a look at a few cases now and focus on how we might work with patients to talk through treatment options as well as safety considerations while they are on therapy. So the first patient is Matthew. He's a patient with newly diagnosed advanced renal cell carcinoma. He's a 55-year-old man, originally presented with hematuria, flank pain, palpable mass in the abdomen, dyspnea, weight loss. So I would say, these days findings or clinical presence that we don't see that often anymore since we use scans so early for many different reasons. But this is a patient who also had a low hemoglobin, elevated neutrophil count, decreased performance status, and imaging studies show already metastatic disease to the liver. And so this is a poor risk patient. And Lee, how would you approach a patient? How would you think about this patient? What his treatment options are, and how would you discuss those with the patient?
So I would first, talk to myself and ask myself what options would be available to him. And of course, as you discussed previously, the combination checkpoint inhibitors would definitely be something that he would be a candidate for. And so with that in mind, I would present, what our goal of therapy would be for him, which by and large, I would mention that, it's ultimately disease control with, and what I would expect Nivo and Ipi together would do for him. Most of the time, we would hope to achieve, a partial response, getting some disease control for a period of time. But, there is that, percentage of patients that may achieve a durable response, and I would try to walk him through what to expect, following that up, of course, with the kind of adverse events and checkpoint inhibitor adverse events that he would experience.
Very good, very good. Yeah, so certainly he's a poor risk patient, so this is a patient who needs treatment now. So this is not somebody like, with favorable disease. Sometimes we just say, okay, come back 3 months later, 6 months later, let's do another scan. Are your little lung node is a little bit increasing? This is somebody who has aggressive disease, large tumor burden. He needs therapy now. And I think any of the FDA-approved treatment options are very reasonable. At this point in time, we do have more follow-up data for Nivolumab, Ipilimumab, and this is a fairly young gentleman, 55 years old, so he's almost like 12 years younger than what the median age of diagnosis is. This is somebody where we would be aggressive. We do know from some follow-up data from 2020 that some of these patients who are treated with combination immune checkpoint inhibitors, for example, can have very durable responses, progression-free survival of 35% with 42 months follow-up. So some patients can do extremely well, and any regimen is fine. But I would say in somebody like this, I would agree that Nivolumab, Ipilimumab is a very good choice, and could have the potential for durable responses. So let's assume that we start him on Nivolumab, Ipilimumab. How do you educate patients about immune-related adverse events? Like how do you approach it when you see somebody in front of you and try to create a safe setting?
Certainly. So I again first try to preface all the treatments I offer patients with at least relatively straightforward explanation of the pathophysiology and the mechanisms of these medications that we offer. And of course, because the checkpoint inhibitors work primarily by activating the immune system, I mentioned that the immune system can oftentimes be blind to what they may attack, and that can include any organ in the body. And then I really emphasize the organs of interest, especially in combination immunotherapy. We talk about the most severe checkpoint inhibitor toxicities, the lung, the heart, but often, and then there are the common severe adverse events. We have colitis, we have hepatitis, and then oftentimes the endocrine adverse immune-related events, which more often than not are irreversible once they occur. So I do try my best to walk them through how they would experience them, what to look out for, but that really with checkpoint inhibitors, the adverse events are myriad and can really affect any organ system in the body.
Very good, very good. So let's assume he responds to therapy, but let's say after the 4th dose of Nivolumab, Ipilimumab, he calls you up and says, "Hey, I have more and more loose bowel movements, clearly elevated above baseline. Looks like a grade 2 by frequency." How would you manage colitis of this grade? What would you do?
So with grade 2 colitis, I would have to withhold checkpoint inhibitors for the time being and start systemic steroids until I can at least get him down to a grade 1 colitis, and then only then would I reconsider rechallenging him.
Do you get stool studies done, colonoscopy? What else would you consider, or just start steroids? What do you do?
Certainly. So I would consider stool studies to kind of help guide things. Now, with the dual checkpoint inhibitors, I think I have a little more leeway in deciding what specifically this colitis is. I don't have the challenge of trying to decide whether or not this is a TKI-related event versus a checkpoint inhibitor-related event. That said, that's probably how I would approach things. But as you mentioned, infectious colitis would definitely be a consideration.
Yeah, very, very good. So certainly, I mean, the good news here is, 2 drugs with similar, if you will, mechanism of action. So if you do get, durable, frequency of bowel movements, this is autoimmune until proven otherwise. You don't have the confounding overlapping toxicity of a tyrosine kinase inhibitor. If he is towards the end of his combinations with Nivolumab, Ipilimumab, remember we just give 4 of these doses and then you switch over to monotherapy. Ipilimumab really, I would say, is the most common offending agent when it comes to colitis, hepatitis, inflammation of the pituitary gland. And so these toxicities are driven typically by Ipilimumab. If it were in the early, first, second cycle, and I want to see, let's say, how severe is the inflammation, even when I start steroids, I may just start steroids already and then take another extra look sometimes into the colon. Do I see, impressive macroscopic changes, or is it fairly bland looking? That may or may not persuade me to pursue further Nivolumab, Ipilimumab combinations afterwards. So it depends on the grade, depends on how impressive the changes are. If I would, risk more exposure to some of these particular agents. But if you go from combination therapy to monotherapy, and if some of these side effects are less likely to occur with the PD-1 inhibition alone, then typically there is very little problem with, after this event has been addressed, to move them over to monotherapy. One thing I feel that sounds difficult to convey to patients is the by themselves, if you will, never-ending nature of some of these side effects. So if you get these diarrhea, the shortness of breath, the pneumonitis, hepatitis, you name it, it typically does not resolve by itself until it's intervened upon. That's one of the really important things to talk with patients about, that the longer the wait, the worse it's going to get, and the higher the grade of the side effects, and maybe even with the higher grade of the side effects, the chance to, for example, re-challenge becomes significantly smaller. Grade 3, 4 toxicities, you really need to jump on those. Again, some of these grade 2, we may already intervene with steroids, so they never become grade 3, 4 toxicities. But these are the ones that we worry about the most. Typically means rapid initiation of high-dose steroids. We do want to see that those side effects get better early, within the first few days. Some patients may require hospitalization for that reason, monitoring oxygen, lung function, for example, that their headaches are getting better from significant hypophysitis, the diarrhea is getting better, etc. If you have significant diarrhea, maybe your absorption of steroids is not good. You may need to be admitted for the hospital for systemic steroids, or some of the other more impressive side effects such as myositis, or other more rare side effects. But it's important to start immunotherapy. You want to assess what happens within the first few days of starting high-dose corticosteroids, and then really have a low threshold of potentially adding on other immune suppressive agents such as mycophenolate and infliximab, or other agents depending on the side effect profile. In general terms, though, the need for additional immune suppressive therapy on top of high-dose steroids is in the single-digit range. So it's not an often occurrence, but the more frequently you use these agents, that can certainly be happening. Also, it tends to be that the side effects for dual immune checkpoint inhibition tends to be a little bit more ferocious and early occurring than with PD-1 monotherapy. Several societies have guidelines published. ASCO has recommendations on how to manage them, the SITC Society for Immunotherapy in Cancer. And I think it's quite helpful to have these at hand. Now let's reimagine Matthew's case. So Matthew is still a 55-year-old gentleman, but this time he presented with hematuria and actually only stage 3 disease. So no synchronous metastases. He had his kidney removed with a tumor, higher risk for recurrence. He underwent regular surveillance imaging studies, but then disease progression was noted in the chest in the form of 2 enlarging lung nodules. Now this time he has no symptoms. He has no major lab abnormalities, and he by all means demonstrates favorable risk, and that would certainly expand his treatment options. How would you counsel a patient with a diagnosis of favorable risk renal cell carcinoma, Dr. Lee?
Given that he has favorable risk disease, I would definitely open up combination TKI and IO as an option for him. So for the most common one I end up using in practice is Pembrolizumab and Axitinib. Very good.
So, so that combination was chosen, and how would you educate him on the potential side effects with IO TKIs?
And so this is the part where I actually would probably spend even more time than the Matthew of the previous case. In addition to talking about all of the checkpoint inhibitor immune-related adverse events, I also go over the non-overlapping toxicities, particularly the VEGF class effects such as palmar-plantar erythrodysesthesia, hypertension, hypertensive encephalopathy, PRES, and the renal injuries as well. While a lot of these overlap, I think that we really do have to talk about what Axitinib can do as well.
Great, very good. So yeah, so again, Fabry patients, I find myself also actually quite challenged to discuss actually the many treatment options. These are often patients who may not necessarily start actually systemic therapy. Sometimes we can watch them if you are 80 years old and have two very slowly enlarging lung nodes. Sometimes we just watch you irradiate these tumors, giving you the benefit of doubt of maybe oligometastatic disease. Younger patients, sometimes we also still use high-dose interleukin-2. Nivolumab, Ipilimumab, while it's not officially approved for Fabry disease by the FDA, it's still part of the guidelines, and we know that some patients can do extremely well, with roughly 13% of patients achieving complete responses. Let's assume he responds to therapy but experiences hepatotoxicity. How would you manage that event? So liver function test elevations on Axitinib, Pembrolizumab.
So I would take advantage of Axitinib's short half-life and hold it and observe the patient over the next 2-3 days and repeat labs at that point. If I see the LFT start to improve, I think I could safely attribute the hepatotoxicity to the Axitinib rather than the Pembrolizumab, and can continue therapy with Pembrolizumab without interruption.
Very good. Yeah, I mean, so certainly the half-life of Axitinib, the short half-life, I think makes it one of the darling, if you will, of current combinations and the current strategies, if you will, to combine PD-1 with tyrosine kinase inhibitors. Thank you so much for this case. Welcome back. This is Dr. Hammer speaking. In this segment, it will be my pleasure to welcome one of my patients, actually, Robert Wilonsky, to this discussion in order to explore his experience with modern renal cell carcinoma therapy. Before we turn to Robert's story, I wanted to share some very interesting survey results conducted by K-Secure, which is a non-profit organization co-founded by Dina Battle, comprised of patients, caregivers, physicians, and medical researchers dedicated to funding accelerated research for kidney cancer treatment. The following slides include data from a survey of over 1,000 patients with renal cell carcinoma. Findings from these studies were presented earlier this year at ASCO GU 2020 conference, and are also part of the virtual AUA and ASCO conferences. I think these surveys findings will give us a window into the broader patient experience, which will be a useful starting point before coming back to Robert and learning more about his story. So one of the questions was, when thinking about the treatment available for kidney cancer, regardless of whether you have used these therapies, in your view, which therapy is the most effective? So remember, we just talked about the tyrosine kinase inhibitor, the targeted therapies, immunotherapies, and combinations thereof. And as you can see, the majority of patients said, I don't know. So it's very clear that patients will require guidance from physicians with regards to therapies, with regards to the side effects. Often they may not have experienced one or the other, and so they can't really tell what some of the differences might be. There are some notions that maybe combination immunotherapy is toxic, but roughly immunotherapy plus TKI is roughly in the same range of almost 20%. So it's all over the place. There's also a few patients who know about high-dose IL-2. Again, there's a bias there. Some patients will never have been told about high-dose IL-2. It's a treatment being done in the intensive care unit. And then certainly TKI themselves, which also have a significant side effect profile. So again, indicating again that patients do well if they talk with their physician about therapies to really broaden their knowledge base when it comes to these kinds of available options. Another question is this one: when thinking about the treatments available for kidney cancer, in your view, which therapy has the harshest side effects? And again, almost 40% of patients said, I'm not sure. So there's a large proportion of patients who really would like to hear from their physician about what kind of side effects is harsher, which one is worse than the other, and how do I rank them, how do I think about them. In this case, high-dose IL-2, 25% of patients So a large number of patients think this is a particularly difficult therapy to tolerate, and it's true, these patients go in the intensive care unit, but again, the quality of some of these side effects are very different. Acute toxicity versus chronic toxicities, for example, with the tyrosine kinase inhibitors, or kind of like a roll the dice, which kind of side effect you're going to get with immunotherapy or combinations with immunotherapy. So again, up to the physician to really spend the time, especially with the first few visits, to talk about available treatment options in the first line for patients. Another question is, when thinking about therapy for your cancer, based on your current situation, what is the most important desire or outcome you want to see from treatment? And patients were asked to rank those. And as you can see, an overwhelming majority of patients had chance of eliminating all evidence of disease. And I think that's very natural. That's where we really want to be, is you go to an oncologist, you were diagnosed with cancer, and the oncologist says, well, good news, we have a therapy that may actually get rid of your disease for good. That's what we really want when we talk about cancer in 2020. Now, just a reminder, immunotherapy, at least the broadly available immunotherapy, really started at the end of 2015 with actually just Nivolumab, just PD-1 inhibition. So we've come a long way to actually, even in the first line, talk with patients about therapies that actually have potentially curative potential, meaning getting rid of the disease for good and durable responses. So again, durability, maybe patients didn't know exactly what it was, but clearly they ranked eliminating all disease over durability of response. They rather not see the disease than having something that has shrunk but is still sitting there, if you will. But essentially, if you look at all these points, it's really about, I want to go full in, I want to get rid of the disease, and there's lesser of concern with regards to toxicity or cost. Patients know that this is a very serious condition, and they want to really get the most out of this particular treatment. Another question was regarding treatment discontinuation. Current treatments for renal cell carcinoma require continuous therapy. However, research suggests that patients might be able to safely discontinue therapy after a period of time and maintain efficacy. If your doctor suggested stopping your therapy because your disease was well controlled, how would you feel? And here you can see that a majority of patients would be anxious about cancer progressing. Very understandable. Patients were treated with a therapy, they have a good outcome. They really do not want to risk losing their position in the fight against cancer. So there really is a need for the physician to really sit down with the patient and talk about why we can sometimes stop therapy. And again, there's even a stopping therapy, not only for immunotherapy in some patients, but also some patients who may have a uniquely sensitive disease to tyrosine kinase inhibitors or targeted therapy. So again, putting things into context, where is the patient, for example, in comparison to other patients, and is there a real chance to potentially come off therapy, and maybe weigh that against the potential side effects of chronic treatment. So the next slide I actually find particularly interesting. So the question was, when experiencing the following side effects, when would you notify your doctor? And that's an important question, because we spend a lot of time teaching patients about the side effects, the significance, and why it is important, in particular with immunotherapy, to rather report early. So we do want to see patients who report in the immediately to after 2 to 3 days range. We rather hear from patients early than later if they have side effects such as diarrhea, shortness of breath, abdominal cramping, blood in the stool. So side effects where we are worried about that patients may actually have significant inflammation of some of their organs, which, if patients wait, could lead to significant sequelae. So when I see that, wait until your next appointment, it's roughly 40% for diarrhea, or for example, 30% for shortness of breath, that's something where I would pause and say, well, I do think it's really important that we spend some extra time with the patients, that they really understand that some of these side effects that can be life-threatening if left untreated for a longer period of time, that they really contact us earlier. Remember, immunotherapy has moved now into the first line, so patients may not be so comfortable also maybe engaging with the healthcare team rather earlier than later. They don't want to bother the doctor or the nurse, and I think it's really important to address it head on with patients. In fact, I often turn to the spouse and say, if your husband doesn't call, most of the patients are men, if your husband doesn't call, then you will call us to let us know that something is wrong. So we encourage early communication for these patients for safety reasons. Good. Now let's get back to actually my patients. And to my patient, I would like to welcome Robert Wilonsky to this discussion. Welcome, Robert.
It's always great to see you and to talk to the man who saved my life.
Thank you so much, Robert. So what I'd like to do is to try and give an audience, give the audience a sense of your story before asking you to elaborate a bit on your experience with really modern kidney cancer immunotherapy. Why don't you start by telling us about your immediate reaction when you were first diagnosed with kidney cancer? You were fairly young at the time, or still are.
Well, I appreciate you saying I was fairly young when I was 48, so that's very nice of you. I don't know, my initial reaction was one of, it's weird, I've thought a lot about this knowing we were going to talk about this, and I'm trying to remember. I don't remember being scared, I don't remember being angry, I don't remember being sad. I just remember thinking, well, I guess it was my turn or my time. That's really the initial thought, because keep in mind that I had gone in thinking that I had kidney stones. And I had gone to see my primary care physician a few days before, and I had asked, I was having some blood in my urine and some pains that were very symptomatic of kidney stones. So I'd gone in for a scan, and my doctor had felt my neck and thought that I had, in fact, thyroid cancer, because I have a swollen thyroid, still do to this day, as a matter of fact. And they said, well, you need to get this scanned as well. So my biggest fear for the few days before I got my diagnosis was that, in fact, I had thyroid cancer, only to find out a few days later that no, the day before my son's 14th birthday, I found out that I had stage 4 renal cell carcinoma, and my doctor at that point said I had 18 months. So I just said at the time that the only thing I wanted out of all of this was to make it to my son's high school graduation. That was my only expectation at that point, because I was told fairly early on, as you well know, that it was inoperable. So my initial reaction was, just let me see my son graduate high school.
Yeah, that's that was a very traumatizing beginning, and certainly at your age, being all of a sudden being diagnosed with the cancer masses, large mass in the kidney, masses in the liver. You saw Dr. Margulis, who is a very aggressive kidney cancer surgeon, who also told you that surgery was not an option. What did you think when you came to a medical oncologist for the first time? Like, even before seeing us, what were your thoughts?
So it was all very surreal. My mother had been a doctor My mother had been a radiologist for many years at Parkland Hospital. So, there was some medical, she had a lot of friends who were at UT Southwestern and who were at Parkland. So I got the call from my doctor, my primary care physician, on a Monday. He said, you need to bring your family in to see me on Tuesday. I said, well, are you going to tell me that I have cancer? He said, I'm not going to tell you you don't have cancer. So Tuesday night, my mother, my father, and my wife went to see Dr. Calliser, who's also my mother and father's doctor. And at 4:30 that afternoon, he told me that I had stage 4 kidney cancer, and that it had spread to the liver and to the lymph nodes, and as far as he could see. My mother had made a phone call to a colleague of hers who she knew very well and asked her for her advice. It just so happened that this colleague of my mother's was in Russia at the time, but she recommended that I immediately go see Dr. Vitaly Margulis at UT Southwestern, who, as you say, was a very aggressive surgeon. So that Thursday, having never been to an oncologist, I went to see Vitaly. And he said, that he would not operate on me because if he were to do so, I would die. The thrombosis kept coming up quite a bit, and certainly he said that if he were to operate, it would do no good anyway because it was so widespread that I probably didn't have a long time. At which point he said, but I do have a colleague, Hans Hammers, who's come from Johns Hopkins, who you may want to talk to. He's involved in some clinical trials, and he may be able to prolong your life, if not save it outright. So I saw Dr. Margulis on a Thursday, I saw you on a Friday, and that was a hell of a weekend after that.
Yeah, so when you saw us, we saw you as a young patient diagnosed with a very serious condition. That was actually in 2017, so that was actually before all these combination therapies had been FDA approved.
I saw you on July 28th, 2017. It was 2 days after my son's birthday.
That's right, yeah. And at that time, the therapies that we are talking about or talked earlier about, these combination therapies, they were actually not available at the time. In 2017, it was still the era of tyrosine kinase inhibitors in the very first line, purely palliative therapy, significant side effects. When you came to us and when I started talking with you about clinical trials, opportunities, side effects, etc., what was going on in your head at the time?
What was going on in my head? I kept thinking at that particular moment, I remember you sat down with me. You were sitting at the little desk there, and I was sitting next to you, and you got out some paper, just a sheet of typing paper, and got a pencil and started to write down my options. You sort of divvy them up into 3 quadrants. And the last one was the Radvax, was the drug combination and the radiation. I believe you told me about all the side effects at that particular moment. I think chief amongst them was diabetes. That diabetes was one of the big ones that you kept stressing. There were several others, but as I kept saying and thinking over and over, well, there's really only one side effect from having stage 4 kidney cancer, so isn't that going to outweigh any other potential difficulties that might arise from the Radvax? Was I worried about getting chronic diarrhea? Was I worried about getting diabetes? Was I worried about any number of the side effects? Sure. But I was more worried about dying.
Thank you so much, Robert. Yeah, so just for the audience, the trial that Robert mentioned was really, the backbone really was Nivolumab, Ipilimumab. We added at the time some radiation to some of the tumors for some patients, but really the backbone was Nivolumab, Ipilimumab, which is now approved or became approved in 2018. So Robert, when you started with the immunotherapy, like how did it feel to go through it, like the first infusions, etc.? Like, what did you experience?
So the experience itself of getting the infusion wasn't the difficult part. What was difficult is what followed that Thursday night, which is when I got a skyrocketing fever because my my immune system went into overdrive, I guess. So I had actually called Denny and said that, my temperature is 103 or 104. She had suggested at that point that I actually go to the emergency room, and I decided that I was going to actually try to figure out if I could stay home, take a couple of Advil, get under the blanket, and sweat it out. And fortunately, I did just that, just in time for the radiation the next day.
So one day of high fevers, and then it went away?
Yeah, so one day of high fevers, after the first infusion. Then I went for the radiation. Got sick after that because, of where things were, and it wasn't surprising. I had gotten a little nauseous. So the first 2 days were the hardest days. Everything after that, the second infusion went fine. All of the other radiation treatments were fine. drove myself to every appointment, went by myself.
Thank you very much. So the initial time, immunotherapy was started, high fevers, you had some side effects from the radiation. But let's say after the radiation, how did you do then? And then at some point we sat down, looked at the first scan, but we also looked at some of your blood work, right?
Right. So as you recall, the first 3 weeks were great. I'd had the treatment, I had the radiation. It had the added side effect of I actually have not looked that good since I was in high school. I got down to a pretty good 200 pounds, and I really did appreciate that. I've looked back at a couple of pictures from that period and go, how can I get back there without the cancer? The second immunotherapy went just as fine as the first infusion. Everything was great. It was when I came in for the third infusion that you and I discovered that there was an issue with the blood work, and I'll let you take it from there, but obviously things began to change a little bit in terms of where we thought we were going with the trial, and sort of how things changed for the next several months after that.
Right. So when it came to me, first of all, we celebrated an early scan on the trial. We did an earlier scan than what normally we would do, and there was a clear evidence for early disease response, shrinkage in the liver lesions, lymph nodes, and unfortunately at the same time, while we were high-fiving, if you will, the lab results came back indicating that Robert's kidney was affected, creatinine levels were very high, and so I said, well, no infusion today, and in fact we started him early on immune suppressive therapy with prednisone.
Very high dose of prednisone.
Very high dose of prednisone.
200 milligrams.
It was fairly high. We like to hit it early, hard, and then we go down. In fact, you responded beautifully. It was almost back to normal, or back to normal in the first follow-up. And then slowly, with the taper of the steroids, your creatinine function started to rise again. Your creatinine levels started to rise again. Your kidney function started to fall again. And so we decided fairly early on, actually, to add on an additional immune suppressive therapy. There were some ups and downs, but we got it all under control. Then you had been off therapy, and Robert had done really well. Scans looked very, very promising with dramatic responses in his tumors. In fact, they looked so promising that one day I think I told you, right, why don't I send you back to Dr. Margulis and let's see if he has now the appetite to maybe take out whatever is left. How did you how did that affect you? Like, what did you think? Did you expect something like that, or did it?
So I was not surprised, based upon the success that you had seen with the scans, that I may in fact get toward operable. As a dramatic sidebar to all this, my father was diagnosed with kidney cancer around the same time, so that it just became a thing. His was different. His was encapsulated as opposed to mine, which had spread so wildly. So his surgery was actually scheduled before my surgery, and it just became a waiting game for both of us to see who would go first and how we would react. But the fact is, I was very, very, very delighted, clearly, that I was operable. Terrified by what that meant, because I knew the surgery was going to be incredibly dramatic and enormous, which it was. Still feel it every day, the neuropathy that has resulted from it, but we'll get to that in a moment. But yeah, it was, I was terrified of, I had never had surgery before. So the idea of that the first time I would be cut open would be pretty much from side to side to have cancer removed from me. It was a hell of a way to break the manufacturer's seal,
Yeah, certainly that happened. There's no doubt about it. So Robert underwent an a really long surgery, really with the goal to remove everything that was suspicious for cancer that may have been residual. Interestingly, he had these really large lesions in the liver, like child heads large lesions. They carved them out, anything that was left, if you will, but there were no living tumor cells in those spots. There was some residual tumor in the original kidney, so we removed that, but everything else, lymph nodes, and
Took the whole kidney.
yeah, we took the whole kidney out, the lymph nodes, everything. You had a dramatic response, and since then we really just observed you, and now it's 2020 with no evidence of recurrent disease at this time.
So it's May 2020. Next month will be the anniversary, the 2-year anniversary. And I know I have a scan after that, or scanned at that point. So yeah, it's you know, you and I have talked about this a lot. We've done some road shows because of the enormous success that you had with me, and it was terrifying. But in retrospect, because the weird thing is, kind of as you're going through it, you don't feel like you're going through it. I mean, yeah, I had a couple of days where I felt like, you know, I felt bad because of the steroids. I felt terrible because of the immunotherapy kicking in. My quality of life was pretty much exactly the same. In fact, I buried myself in work in a lot of ways to ignore kind of what I was going through internally, or emotionally, or physically, or however you wanted to define it. And I know it could have been awful. And because of what you did for me, because of the trial, because of the drugs, because of the radiation, because of Dr. Raki Hanan, because of Dr. Margulis, because certainly, and most of all, because of you, I just am to this day astounded by how painless such a painful thing was.
Thank you so much, Robert. So thank you for joining me today. I think your insights are very important for patients, and sharing your experiences are really greatly appreciated. I think your story is extremely helpful, informative to both, actually, patients and providers, to better understand the issues that people with a diagnosis of renal cell carcinoma face now and moving forward. Thank you so much, Robert.
Well, you know, I'll do anything for the man who saved my life, so it's always a pleasure to talk about it, because the fact is, I have talked to a number of people over the last couple of years who have gone through what I've gone through, or who have been diagnosed. Many of them have not been as fortunate to know somebody like you, who has, or to have been offered something as dramatic as what you offered me. And I tell them and push them in this very direction, because they do need to know that there is, in fact, a kidney cancer diagnosis is the furthest thing from a death sentence that I certainly thought it was 3 years ago. So, you know, I told somebody recently it was, I'd say it was magic if I didn't know that it was science. And I thank you.
Thank you, Robert. Thank you so much. Thank you for joining us today. I think what we've seen is that the different types of new approaches in the frontline setting represent positive alternatives for patients with advanced renal cell carcinoma. Both patients and clinicians should, however, be aware of differences between the new standards of care: dual immunotherapy versus immunotherapy with tyrosine kinase inhibitor combinations, and be prepared to have discussions about treatment choices that best fit the needs of each individual. Thanks again, and we hope you found this activity informative and useful for your practice.
This CME, MOC, CNE, CPE activity is jointly provided by Medical Learning Institute Incorporated, the Kidney Cancer Research Alliance, KC Cure, and PVI, Peerview Institute for Medical Education.